This is Dr. Thomas Dayspring, Chief Academic Officer at True Health Diagnostics. I want to talk about cardiometabolic diagnostics, specifically LDL biomarkers. It's important to understand how hydrophobic lipids are trafficked in aqueous plasma. In the diagram here, you see collections of lipids, and they are color-coded. But those sort of oil droplets would not be able to circulate in aqueous plasma. What gives the abilities of lipids to move around are they are enwrapped with proteins. And the structural proteins that enwrap the lipids are called apolipoproteins. And there are basically two families. Those particles that are enwrapped with apolipoprotein B and those that have as their surface and structural protein apolipoprotein A1. Of course, lipoproteins also have a nomenclature that uses their density or buoyancy as determined by ultracentrifugation, very low density, and high density. The ApoA1 is the structural protein for the HDL particles, whereas all of the ApoB particles have one molecule of apolipoprotein B. ApoB is also not transferable. It's with the particle from the day it is made till the day it is catabolized. It is crucial to understand that lipid movement is lipoprotein driven. So lipids go nowhere in the human circulation unless they are attached to a protein, and the majority of them are in lipoproteins. This trafficking system gets a little more complicated because we have lipid transfer proteins, which pretty much continuously allow the particles to swap various lipid species for one another. In essence, one molecule of triglyceride can be swapped for one molecule of cholesterol ester. So our particles are in a constant dynamic remodeling situation, and their cores are continuously changing. This is a commonly reproduced graphic that shows you a separation of the human lipoproteins. On the y-axis is their density, with the most buoyant up top and the most dense at the bottom, whereas the x-axis is the diameter of the particle in nanometers. And you see a very heterogeneous collection of lipoproteins. Of course, the lipids are color-coded, so an intensity of blue show triglycerides, an intensity of yellow would be cholesterol-laden particles. Also notice they can be separated by their apolipoprotein content. ApoB is depicted as a brown sort of snake encircling the particles, whereas ApoA1 is red. So you can see, if you want to separate the beta and the alpha lipoproteins, you need to know their apoprotein content. The HDL particles, which contain 1 to 5 molecules of ApoA1, are often referred to as the alpha lipoproteins. The very huge chylomicron is an intestinally produced lipoprotein which goes through the lymphatics before it enters plasma. It's primarily a triglyceride delivering particle. The VLDLs and LDLs are produced and secreted by the liver. A VLDL can also be catabolized down to an LDL. An intermediate particle is appropriately called intermediate density lipoprotein. And notice there's also a type of LDL particle that has an accessory attachment called Lipoprotein Little A, and an LDL which carries ApoA is referred to as Lipoprotein Little A. What's important is the particle that has the potential to enter the arterial wall and deliver its sterols are the ApoB containing particles. Now there are half-life differences here. VLDL particles, once secreted from the liver, have a half-life of 2 to 4 to 6 hours before they lose their triglycerides and shrink down. An IDL particle has a half-life of an hour or two, whereas LDL particles, once secreted or formed, can hang around for 2 to 4 to 5 days. So the overwhelming majority of your ApoB particles are LDL particles. HDL particles, which are in a constant state of remodeling, lipidation, delipidation, on average have a half-life of around 5 days. Let's take a close look at the low-density lipoprotein, which makes up the overwhelming majority of the ApoB particles. So we start with a single molecule of apolipoprotein B, which is synthesized in the liver, and it is lipidated in the liver. The lipids that will start attaching to apolipoprotein B include phospholipids and free cholesterol, and since they have some degree of water solubility, they will be on the surface of the forming lipoprotein. The core will consist of a collection of cholesterol ester, which is cholesterol to which a fatty acid has been attached, which makes it an extremely hydrophobic lipid, as well as triglycerides or triacylglycerol, and that's a glycerol molecule to which 3 fatty acids have been attached. So an LDL is basically an apolipoprotein B particle, and a normally composed LDL has a composition where 80 to 90% of its core is cholesterol ester and 10 to 20% would be triglycerides, which would give it a CE to triglyceride ratio of 4.0 or higher. Of course, in pathologic states, LDLs can be triglyceride rich, in which case they would be cholesterol depleted. Or vice versa, if they had very few triglycerides, they might be very cholesterol enriched LDL particles. And of course, this slide doesn't show it, but we'll get into it. HDLs do exist in a heterogeneous mixture of variously sized and composed particles. And as mentioned, LDL particles are a heterogeneous mixture of particles of varying composition and size, each with a single molecule of apolipoprotein B. We have many LDL particles, but they each are unique particles with their own diameter, their own composition. Many would be very similar, but they can be all over the place as to their content and their size. The larger, more buoyant particles have historically been termed phenotype or pattern A, whereas the smaller, denser, less buoyant particles have been given the name phenotype or pattern B. That doesn't have a lot of clinical use anymore, and very few labs actually report LDL phenotypes or patterns per se. This graphic appears to show 2 low-density lipoproteins with arrows pointing to its single molecule of apolipoprotein B. However, we have mentioned lipoprotein Little A, which is a different type of LDL particle. Attached to ApoB on this particle is a separate peptide called apoprotein or apolipoprotein Little A. And this protein consists of a series of segments that are called kringles. Basically, ApoA consists of a kringle type 4 and a kringle type 5. However, the kringle 4 consists of several subsegments, which are called type 1, type 2, and in types 3 to 10. You can see the kringle 4 1 is color-coded red. The kringle 4 subtype 2 is color-coded green, whereas types 3 to 10 are blue. Kringle 5 is depicted in yellow. The variability of apoprotein A with respect to size and molecular weight totally depends on the number of segments or subsegments that make up kringle 4 type 2. It's very individualized, and that's why the size and molecular weight of ApoA can vary between individuals. Apoprotein Little A has potential to be atherogenic in that it may have procoagulant attributes, and it has an ability to traffic oxidized lipid moieties, which can contribute to inflammation should this particle enter the arterial wall. Now let's discuss LDL biomarkers that are offered by laboratory. Unlike what is commonly thought, there is no lab test called LDL. LDL simply means low density lipoprotein. It's describing one of the human lipoproteins. If you would like to find out clinically useful information about an LDL, there are several metrics or assays one can request of the laboratory. In our graphic here, right in the middle is the entire LDL particle. On the left is the molecule of ApoB that enwraps it. On the right are several cholesterol ester molecules. So what you can order in a laboratory, on the top you see LDL-P NMR. That means low density lipoprotein particle count using nuclear magnetic resonance. It basically consists of all of the larger, smaller LDL particles as well as any LP little a particles that a person may have. Understand, we'll talk about it later, that LP little a-P is an orderable metric, but that is not performed using nuclear magnetic resonance. So when you get an LDL-P back, you're basically being told how many nanomoles of LDL particles exists per liter of plasma. As mentioned before, LDL size can be provided by a laboratory, previously in angstroms, most of the time nowadays in nanometers, and they can be classified as being normal size, small, or large. There is one apolipoprotein B on every LDL particle, and because of its long half-life, LDLs make up the overwhelming majority of apolipoprotein B containing particles. So ApoB is in essence an LDL particle count. ApoB tells you very little about other types of ApoB particles such as VLDLs or IDLs because there are so few of them. Of course, the most commonly used metric in the clinical world is LDL cholesterol. And what that refers to, it's the cholesterol mass that is trafficked by all of the LDL particles that exist in a deciliter of plasma. LDL particle counts or ApoB, you're counting the number of LDL particles. LDL cholesterol refers to the mass of cholesterol that is trafficked by all of those LDL particles that exist per deciliter. And of course, LDL cholesterol has traditionally been calculated using the Friedewald formula, which depends on triglycerides, so you have to be fasting for it. Many labs now perform direct LDL measurements, which therefore do not depend on triglycerides and do not require fasting. Because the LDL particles have such a long half-life, fasting is not required to request an LDL particle count or apolipoprotein B concentration. Let's talk about nuclear magnetic resonant lipoprotein analysis. In this methodology, lipoproteins are subject to magnetic waves, which set off spectral signals as atoms in the methyl groups start to oscillate. And these are naturally distinguishable spectral signals. And through advanced calculations, the spectral signals can be translated into particle sizes and particle concentrations. Now at True Health Diagnostics, NMR is done using a second generation NMR spectrometer, which has much higher resolution power, and that the magnet is 600 megahertz compared to 400 megahertz, which is used in the first generation of apparatus that perform this assay. Let's delve a little deeper into LDL biomarker assays and terminology. And you see on the graphic here 3 LDL particles, larger, intermediate size, and smaller. And you see variable amounts of cholesterol. So a total LDL particle count using NMR provides the number of LDL particles in nanomoles per liter. And it has been highly correlated with risk, and it is used as a goal of therapy, depending on the underlying cardiovascular risk. Now, NMR can also tell a clinician how many small LDL particles are present. Total LDL particle count would be the sum of large and small. Small LDL particles are most commonly seen in diabetics and insulin-resistant patients, and it really serves as a lipoprotein biomarker suggesting the presence of insulin resistance. Now, we've been relying on cholesterol mass measurements for decades. LDL cholesterol, as previously mentioned, is the collective cholesterol mass in all of the LDL particles that exist in a deciliter of plasma. But laboratories can also offer a clinician the amount of cholesterol that is trafficked within the small, dense LDL particles, and that is called SD-LDL-C. That is a very different measurement than small LDL particle count. Small LDL-P gives you the number of small LDL particles per liter in nanomoles, whereas SD-LDL cholesterol gives you the cholesterol mass in all of the small LDL particles that exist in a deciliter. Both are primarily used, one is a lipoprotein metric, the other is a lipid metric, to be indicative of the presence of insulin resistance. Diabetics, insulin-resistant people tend to have more small LDL particles, and clearly they would be carrying more cholesterol than somebody who didn't have a lot of small LDL particles. Total LDL cholesterol is really the sum of the cholesterol in your bigger and your smaller LDL particles. Not shown in this diagram, but remember, LDL cholesterol actually consists of small, intermediate, and big LDL particles, but also any cholesterol that might be trafficked in an LP little a particle, which a person may or may not have. Apolipoprotein B is a commonly ordered metric because they are the potentially atherogenic particles. So, as mentioned, there is one apolipoprotein B on every VLDL, IDL, and LDL particle, regardless of its size or composition. And there is one molecule of a truncated ApoB on every intestinally produced chylomicron. The ApoB coming out of the liver, which is a full molecule, is called ApoB 100. The intestinally produced ApoB, which is truncated and has 48% of the molecular weight of the hepatic produced ApoB, is called ApoB 48. If one orders an ApoB level, you're getting both. However, if one is fasting, there almost never are any chylomicron particles, but even in a postprandial state where chylomicrons exist, although they're large and they carry a very significant amount of lipids, especially triglycerides, there are very, very few particles. So chylomicrons, except for very rare conditions, do not really contribute to an apolipoprotein B measurement. Now, of course, an LP little a particle is an LDL variant, so every LP little a molecule has one ApoB on it. So in persons with a lot of lipoprotein little a particles, that would also contribute to an ApoB level, period. So this diagram shows you the intact particles, but if we extracted the ApoB from them, you see them below, and they are amenable to assays in laboratories, and they would be reported in milligrams per deciliter. And basically, ApoB serves as an LDL particle count, because if you look at all those particles, the half-life of the LDL is several days, where the half-life of all those other particles is minutes to a few hours. Here we have a graphic entitled apolipoprotein B cholesterol, which is not a commonly used term, but it's very important. So the graphic again shows you pictures of all of the ApoB containing lipoproteins, from VLDLs, chylos, IDLs, LDLs, and lipoprotein little a. But of course, what is their cholesterol content? Well, it would include all of the cholesterol that are in VLDL and any chylomicron particles that are present. But it also includes all of the cholesterol that would be in intermediate density, low density, and LP little a cholesterol particles. In essence, that is your ApoB cholesterol. And it actually is better assay of potentially atherogenic cholesterol than is LDL cholesterol. So they came up with a very intuitive name for this, and since it's the cholesterol that is not in your HDL particles, it is referred to as the non-HDL cholesterol measurement. And it's a very simple calculation. One takes total cholesterol, one subtracts from it the HDL cholesterol, and what you're left with is VLDL cholesterol, IDL cholesterol, LDL cholesterol, LP Little A cholesterol. It's your ApoB cholesterol. And many guidelines are moving towards making this a better goal of therapy. Some are even using it as a risk assessment tool. So it is simply a calculation for a lab. Since neither total cholesterol or HDL cholesterol requires fasting, this metric can be done in a postprandial situation. Of course, atherogenesis is the dreaded complication of abnormal lipoproteins. And atherosclerosis is the buildup of plaque, which is basically cholesterol-laden foam cells, smooth muscle cells, and inflammatory molecules that occur over time. The sine qua non is to have cholesterol or a sterol deposited in your artery wall. And the only way that gets into that location is as a passenger inside an ApoB containing lipoprotein, of course the vast majority of which are LDLs. So the number one factor that is associated with LDLs entering the arterial wall is not LDL size, not LDL cholesterol, but rather LDL particle count, or of course apolipoprotein B. The probability that a particle's cholesterol will be delivered to the plaque depends mostly on LDL particle number. How many LDL particles enter the artery wall, how many become oxidized, and finally how many are taken up by those macrophages, which will transform into foam cells. So that's why LDL particle count, or ApoB, are at the top of the metrics related to lipoproteins that are associated with atherogenic risk. And of course now we're going to look at LDL composition and size, and it's really what explains why it is necessary to measure LDL particle counts or apolipoprotein B, and not to just assume they always correlate with cholesterol measurements. So we start off by looking at two different LDL particles. One is a fluffy, buffy, buoyant particle, and the other is a small, dense particle. If you divide LDL cholesterol by LDL particle count using molar concentrations, you actually come up with a number that refers to the number of cholesterol molecules that would be in the average LDL particle. So you notice the larger particle on the left is carrying 2,600 molecules of cholesterol, whereas the smaller particle, as you would expect, is carrying fewer molecules of cholesterol, calculated as 2,150. A smaller dump truck can carry less things than a bigger dump truck. Now, if both of those patients had an LDL cholesterol of, say, 70 or 100 milligrams, it would require more of the smaller particles to traffic that collective amount of cholesterol. So the person with a smaller LDL would have a higher LDL particle count. But it's not all size. Let's look at another LDL particle. It's a big one, it's buoyant, but it is very blue, which means it's a triglyceride-enriched LDL particle. If an LDL is triglyceride-rich, it necessarily has to be cholesterol-depleted. So interestingly, that large LDL is only carrying 2,150 molecules of cholesterol, virtually identical to the small, dense LDL to its right, and far less than the larger LDL to its left. So not only particle size is a variable here, but particle composition. If one took the ultimate extreme, having a small LDL particle that is also triglyceride-rich, they carry even less cholesterol molecules per particle, and they are associated with the highest LDL particle counts. Because it would take a heck of a lot more LDLs capable of carrying 1,700 molecules of cholesterol than it would carrying 2,600 or 2,150 molecules of cholesterol. So LDL particle count is related to not only LDL size, but LDL composition. And the less cholesterol per particle than the normally composed LDL, the higher will be the LDL particle count. And this explains why, although they often correlate LDL cholesterol and LDL particle count, depending on the given makeup of an individual's LDL particles with respect to size and composition, the LDL particle count may be very, very different than is the LDL cholesterol level. And in such circumstances, clinical trials have shown that risk always follows the LDL particle count, not the LDL cholesterol. Here I want to discuss lipoprotein little a biomarkers. Virtually all of the labs in the country report this metric as lipoprotein little a mass. And what does that mean? Well, a lipoprotein little a particle consists of a collection of esterified cholesterol, free cholesterol, triglycerides, phospholipids, apolipoprotein B, and of course whatever isoform of apoprotein little a given individual has, and in some people that's at least 2. On odd occasion, there can be other apoproteins on LDL particles, such as ApoC3 or ApoE. And there can be many, many other lipid moieties also. So LP little a mass is basically weighing all of those contributing factors. So it's a highly variable metric. True Health Diagnostics is the only lab that gives a clinician an actual LP little a particle count. Now notice LP little a particles, like LDL particles, are extremely heterogeneous. The LDL component could be big or small. It could be triglyceride enriched or cholesterol enriched. And remember, triglycerides have higher molecular weights than cholesterol. This, depending on the size of the particle, the phospholipid content would vary. But the ApoA or ApoA isoform is very variable. Some people have a lot of copies of that Kringle 4 type 2. Others have only a few. So you can see where an LP little a mass metric would have far more variability than an LP little a particle number metric. And we certainly know with respect to LDL particles and HDL particles that the particle number has turned out to be a more valuable metric in regards to cardiovascular risk than does its lipid content. And is the same true for LP little a particles? Future studies will determine that, but certainly it is intuitive that an LP little a particle count may well be the most desirable metric when assaying risk related to lipoprotein little a. For atherogenesis to occur, apolipoprotein B containing particles, the vast majority of which are LDLs, pass through the endothelium and enter the arterial wall, where they are subject to free radicals and reactive oxygen species to an oxidative process, creating fully oxidized LDLs. They then can be internalized by monocytes turned macrophages, leading to the formation of foam cells, the histologic marker of plaque. LDLs that are fully oxidized do not exist in plasma because plasma is full of rich antioxidants, and any oxidized LDLs would be rapidly removed by scavenger receptors in various tissues. However, minimally oxidized LDLs are not as readily cleared, and they do exist in plasma. And in fact, it is minimally oxidized LDLs that become measurable in the laboratories. When an LDL is oxidized. It is the phospholipids that are oxidized, but it is also some of the amino acids that are on apolipoprotein B. And oxidation allows the lysine residues on ApoB to be substituted by aldehydes. And that transformation changes the conformational shape of ApoB, allowing certain epitopes, which can be recognized by antibodies, to exist. Let's talk about the assay for oxidized LDL. It's not widely known, but these assays detect minimally oxidized LDL particles, which are actually present in plasma as a very minor fraction of total LDL particles. As you can see, they're virtually non-existent in healthy persons, but they can be up to 5% of total LDLs in patients experiencing acute coronary syndrome. Of course, small LDLs, because of their smaller surface size, carry less antioxidants and are more prone to oxidation. And it should be no surprise that oxidized LDL concentrations certainly correlate with total LDL particle and LDL cholesterol concentrations. They are very different assays looking at different aspects of an LDL, but there is a correlation between all of those markers. Now, with respect to the assay, it's a solid phase two-site capture, or commonly known as a sandwich ELISA, with ELISA standing for enzyme-linked immunosorbent assay. The assay uses two monoclonal antibodies. One is directed at specific epitopes on oxidized ApoB. And as you can see, the antibody is attached to a microteter plate, and it will attach to the oxidized portion of ApoB, fixating that oxidized LDL particle. Once that step is done, a second antibody is introduced, and this antibody is conjugated to a specific peroxidase. Now, this antibody attaches to non-oxidized portions of the ApoB. So in the diagram, you see you have oxidized LDL, which is fixed to a microteter plate. It now, on a different aspect of its surface, has another monoclonal antibody to which a peroxidase is attached. That plate is washed, and then the plate is exposed to a substrate which reacts to the peroxidase on the antibody attached to ApoB, which creates a colored reaction product, which can be measured. So those are the steps necessary, what the laboratory performs, to give us an oxidized LDL concentration. So in summary, here is a list of the LDL biomarkers that are offered at True Health Diagnostics. It's total cholesterol, a very poor ApoB or LDL particle metric. It is LDL cholesterol, the most conventionally used, non-HDL cholesterol, which guidelines at least are moving to as a goal of therapy, and then the more accurate measurements, apolipoprotein B, LDL particle counts. You have both small LDL particle counts and small LDL cholesterol, which are reflective of the presence of insulin resistance. You have the Little A particle count, and you have oxidized LDL concentration. Of course, all have an optimal range, a range that is somewhat abnormal, and a range typically associated with higher risk. And it's very easy to interpret because the concentrations that are reported are color-coded. With respect to lipid and lipoprotein metrics, I wanted to mention the fact where some of these numbers or risk categories come from. All of these markers like LDL cholesterol, ApoB, LDL particle count have been measured in multiple epidemiological and clinical trials. And these numbers you see before you come from the multi-ethnic study of atherosclerosis or MESA or the Framingham offspring study. Now, in any population, there's going to be a rather wide distribution of markers going from the lowest value that was seen to the highest value. Most of these turn out to be bell-shaped curves with many people in the middle. So if you are in the middle of that bell-shaped curve, that is the 50th percentile population cut point. That means 50% of the people have a lesser concentration, 50% have a higher concentration. For those of these markers before you that exceed the 80th percentile population cut point, that is usually, at least in studies that looked at cardiovascular risk, associated with high risk. If you happen to have a concentration that is below the 20th percentile cut point, that is usually considered in the optimal range and is not usually associated with cardiovascular risk. The 5th percentile population is used as a potential goal of therapy in those who are at the most extreme risk for atherosclerotic complications. So when a various guideline issues a goal of therapy, you can say, it's the 20th percentile. Or if they're saying it's a risky marker, it's probably higher than the 80th percentile. The last topic to discuss is concordance and discordance. You can have somebody whose LDL cholesterol is down around the 5th percentile, which seems spectacular, yet their ApoB or LDL particle count could be significantly higher in the 50th or 80th percentile. Those two markers, which typically correlate, would be said they are discordant. If an LDL-C is in the 5th percentile, but the LDL particle count is at 770 or below, the two markers are said to be concordant. Then they are equally valuable as ascertaining risk. The problem is, unless you're doing both measurements, you will never know in a given individual patient who might have discordant concentrations. I hope you enjoyed this dissertation on LDL biomarkers, and there's always more to learn, and we have a number of materials for you here at True Health. Thank you very much for listening.